So thank you very much. And first, before this presentation, I disclose that I'm a member of the Medical Advisory Board of MAC Culture. How to measure cardiac outputs accurately? In fact, answering this question was very simple a few years ago, 40 years ago, because the only device we had on the shelf was the PA catheter. But as you know, during the last 40 years, many other devices have emerged for measuring cardiac output. What about their accuracy? And one must say that it remains that the gold standard, the reference method, is still the PA catheter. But as you know, the main problem is that it's not very easy to use this catheter, and I strongly believe that it's the main reason why the other devices have emerged. And among those devices, the other dilution techniques, are these techniques accurate? Actually, these techniques are much easier to use than the PA catheter because they do not require any pulmonary artery catheter. With the transpulmonary thermodilation devices, you just need an iced bolus to inject, and you just need an arterial catheter, simple arterial catheter, and the same with the lithium dilution and the LITCO device. What about the accuracy of these dilution devices? I won't go in the deep detail of the validation studies concerning these transpulmonary dilution devices. It would be a little bit boring. But for instance, what's interesting to see is that concerning the last device, the ED1000 device, in this validation study, yes, it's the newest device and so it's a recent validation study, the reference, the gold standard that was used to validate the method was not the PA catheter anymore. It was the other transpulmonary thermodilation device, namely the PICA device. And so I think that if we want to get across some important messages, the first one likely today should be that techniques using marker dilution are likely the most accurate. But also the problem with the techniques is that there are still invasive techniques requiring a central venous catheter and arterial catheter, and it's the reason why some other less invasive techniques have emerged. Among these techniques, very popular techniques are the uncalibrated pulse filter analysis devices. What about their accuracy? And to answer the question of their accuracy, we must understand how they work. How do these uncalibrated pulse filter analysis methods estimate cardiac output? In fact, as you know, with these techniques, you measure blood pressure and you have the pressure curve, and from this curve you obtain cardiac output. It's magic. In fact, it's not really magic because it's based on physiological principles, which are the following. First of all, with these devices, you use the physiological principle that stroke volume is proportional to the amplitude of the aortic pressure. Second principle, the relationship between stroke volume and aortic pressure, and it's very important to keep in mind, is influenced by the vascular compliance and by the vascular resistance. Third, what these devices measure is not the aortic pressure, of course, it's the peripheral pressure, for instance, the radial or femoral pressure. And so the principle is that aortic and peripheral pressures are related and linked through the pulse wave amplification phenomenon. And lastly, this pulse wave amplification phenomenon depends on the vascular resistance. Why is it important to remind this? Because it's obvious that the reliability, the accuracy of pulse filter analysis is highly dependent on vascular resistance. And it's been shown by many studies that if vascular resistance changes to a large extent, pulse filter analysis devices are less accurate. Just an example, with this study we conducted a few years ago with Jean-Louis Degout, with this uncalibrated pulse filter analysis device, the Galileo, we tested its accuracy in two different populations of patients. Patients receiving volume expansion, meaning no change in the systemic vascular resistance, and another population of patients in whom we changed the dose of norepinephrine. And you see here that it was not the same at all. The Vigilaire was able to track the changes in cardiac output quite reliably. In the patient receiving volume expansion, it was not the case if the changes in cardiac output were induced by changes in norepinephrine. If the vascular resistance changes to a large extent, uncalibrated pulse control analysis is not accurate anymore. Another illustration comes from this Japanese study here. In this patient undergoing cardiac surgery, again with an uncalibrated pulse control analysis device, the authors administered phenylephrine, and you see that the percentage error that must be below 30% was good if the systemic vascular resistance was normal, much poorer if the SVR was low, and even poorer if the SVR was high. Another nice illustration of the same concept comes from this study by the team of Maxime Canesson. And these patients, cardiac surgery patients, were submitted to changes, hemodynamic changes induced by phenylephrine, ephedrine, and whole-body tilting. And the preload changes induced by whole-body tilting, meaning no change in the systemic vascular resistance, were pretty well tracked by the uncalibrated device with a good concordance rate. It was not the case if the vascular resistance was changed, and you see that in such cases the concordance rate was much poorer. And so it's not only the published evidence, but also the basic physiology that tells us that definitely uncalibrated pulse control analysis devices are not reliable when the vascular resistance changes to a large extent, either due to septic shock or to vasopressor administration. And I think that it's an important message we must keep in mind. Beyond these less invasive devices, and even more recently, non-invasive devices have appeared. And among these devices, I would like to insist on these volume clamped devices. Are these new devices accurate? And again, we must understand how they work to answer this question. With the volume clamp method, you just need a cuff around the finger to measure cardiac output. It means that these are totally non-invasive devices. Because incorporated in the cuff, there is a photoplate tomography device that allows to measure the volume of oxygenated blood, meaning the diameter of the finger arteries. And then the cuff inflates and deflates continuously in order to keep the diameter of the finger arteries constant. And the principle is that the pressure that's required to inflate or deflate the cuff is used to estimate the blood pressure. And that's why these devices allow us to obtain a totally non-invasive pressure curve. And the last step of these devices is to estimate cardiac output from pulse control analysis. Are these devices accurate? And here one must say that there is a discrepancy in the literature. You could find some good and poor studies. But if you look into details, it's interesting to see that the good studies were published in patients in the operating room or even in normal subjects, while the studies demonstrating a poor accuracy of the volume clamp methods were conducted in ICU patients, and especially ICU patients receiving vasoactive agents. These two studies were these ones, one published by our team with Jean-Louis Deroule, and you see that the percentage error was much higher than 30%, and another published by the team of Jean-Luc Fellaini. And you see that in these studies, a large proportion of patients receive vasoactive drugs, likely impeding the ability of these devices to measure the photoplethysmography signal. And so for these devices, one must say today that they are not reliable, at least in the most severe ICU patients receiving vasopressors. And more generally, I think it's possible to say that the technological trend today is to develop less invasive devices, that the reliability of such devices, especially for the most severe patients, should be still improved. The fourth message is that it's not only a question of accuracy. And we should look at all these devices, not only in terms of accuracy, but also in terms of precision and trending ability. It's very important. Trending ability, it's obvious that, in fact, we are much more interested in changes in cardiac output than in absolute values of cardiac output. For instance, in this patient, I don't care whether the cardiac output is 3 or 4 or 4.8. I'm much more interested to know that cardiac output changes from 9 to 10 a.m. or from before to after volume administration. Actually, accuracy is not all, and we should look at the ability of these devices to track trends in cardiac output. And for instance, there are some devices that have a poor accuracy, like for instance this one we tested in this study, but a quite good trending ability. And here you see the percentage error was very high, but the trending ability was much better. It's not only trending ability, but also precision. And precision is not the same than accuracy, and we must keep that in mind. And it was pretty well defined here, this difference between accuracy and precision, in this nice paper by Maurizio Cecchini. Accuracy can be defined as the distance of the average of your measurements from the true value, 1. The precision could be defined as the distance of values between each other, the ability of the device to give some values that are close one from the others. And it's very important because if the device is very precise, then it means that the least significant change is very low, that you can trust even small changes in cardiac output measured by the device. So what's the least significant change of the devices we have on the shelf? And let's take the example of the transpulmonary simulation devices. In this paper with the lithium dilution, Maurizio Cecchini and Andrew Rhodes showed that if you use 3 injections of lithium, then the least significant change is 14%, and it's quite good. It's not far from the values obtained with a PA catheter. With a similar study, but this time with transpulmonary simulation, bigger device, in this study with Romain Cecchini and Jean-Louis Degout, we showed that, again, the least significant change was 12%. It's quite good. Okay. But what's up with the other devices? And here there is an important message. The pulse control analysis devices have a much better precision than dilution techniques, meaning that the least significant change of these devices, pulse control analysis devices, is lower. And you can trust changes of cardiac output as low as 3%. It's very useful, especially if you look, just for instance, for example, at the changes of cardiac output induced by the end expiratory occlusion test. You know this test, I won't go into detail, but you know that we developed this test in order to predict fluid responsiveness. The principle is that in a patient under mechanical ventilation, each insufflation changes cardiac preload. And so, if you interrupt mechanical ventilation at end expiration, then you allow the cardiac preload to increase. But the problem is that to detect the small changes in cardiac output induced by this small change in preload, you must have a very precise technique. It's not possible with dilution techniques, but it's possible to test fluid responsiveness by the means of this test with pulse control analysis. And here, for instance, you can see that the small changes in cardiac output can be easily detected by pulse control analysis because it's a very precise technique. It's not only accuracy, but also precision that's important to assess all these devices. Finally, again, it's not only accuracy, because all these devices can measure cardiac output for sure. But what's very different between devices is their ability to provide other information. Some devices only provide stroke volume, pulse pressure variation, or markers of preload. But the most sophisticated devices give a lot of hemodynamic information, with a PA catheter, pulmonary pressure, pulmonary resistance, tissue oxygenation, with other dilution devices, LV contractility, lung water, etc. And so it means that it's not only a question of accuracy, but also a question of the amount of total information provided by these devices. And since these devices also have different invasiveness, it means that we should not use all these devices in the same setting. And there are likely different indications. The most sophisticated devices and the most invasive one, providing the most important information, should be used in the most severe patients, ICU patients for instance, while the less sophisticated device, less invasive, with less information provided, should be rather used in patients at risk in the operating room. It's not the same indication, and it's not only accuracy. The less the invasiveness, the less the hemodynamic information provided. Different devices have different indications. And with this last message, I thank you very much for your attention.